All right, welcome. Today we are diving deep into how to assess a headache using the 2019 BASH guidelines as our map. Think of this as your go-to guide for a simple, safe, and really effective way to make a diagnosis, especially when you're under pressure in a clinic or facing an exam. So let's get right to it. This is the question we have to answer every single time. And the stakes are high, right? If you mistake something serious, like a subarachnoid hemorrhage, for a simple migraine, well, the consequences can be catastrophic. But you also can't just order a CT scan for every single person with a headache. That's where these guidelines are so powerful. They give us a clear path to follow to solve this exact problem. Before you even start thinking about what type of headache it might be, migraine, tension, whatever, your very first job is to put on your detective hat and hunt for danger. The guideline is incredibly clear about this. Safety always comes first. We have to actively look for any signs that point to a serious underlying cause. This isn't just a suggestion, it's the absolute standard of care. Now this slide is where the magic happens. The guidelines basically cut through all the noise and give us these 4 major indicators to watch out for. Just think of this as your non-negotiable checklist. Is it a thunderclap headache? Are there any new neurological signs, like weakness or vision problems? Is there a fever? And is this a brand new headache for someone over 50? If you get a yes to any of these, everything changes. Your whole plan pivots right then and there. Let's zoom in on that first red flag because it is the big one. A thunderclap headache isn't just a really bad headache. What defines it is the timing. We're talking about a headache that goes from 0 to its absolute peak intensity in under 5 minutes. Bang. The guidelines tell us that this specific pattern has the highest chance of being caused by something serious, especially a subarachnoid hemorrhage. If your patient describes this, it's a straight-up, no questions asked referral to the hospital. Okay, so you've done your safety check, you've screened for red flags, and you haven't found any. Phew! Now, and only now, do we move on to phase 2, figuring out which of the common, everyday primary headaches we're actually dealing with. And here's the thing. The vast majority of headaches you're ever going to see will fall into one of these 3 buckets. And the guidelines really emphasize that the secret to telling them apart isn't some fancy scan or a blood test. It's the history. It's all in the story the patient tells you. And this table, this is pure gold. It's basically your cheat sheet, pulled right from the guidelines. Just look at the differences here. A cluster headache, it is strictly on one side. A tension-type headache, usually on both sides, and a migraine can be either. But look at the key features. Someone with a migraine just wants to lie still in a quiet, dark room. Why? Because any activity makes it worse. But a person with a cluster headache, they're restless, they're agitated, they literally cannot sit still. See? They paint completely different pictures. When you think migraine, I want you to think disability. This isn't just a headache. This is a headache that completely takes someone out of their day. The pain is often described as pulsating or throbbing, and it gets worse with simple things like walking up the stairs. You combine that with nausea or maybe sensitivity to light and sound, and you've got yourself a classic migraine. Okay, now let's flip the coin and look at a tension-type headache. This is the most common one you'll see, but it's not typically disabling. The classic description is that feeling of a tight band pressing or squeezing around the head. And here's the crucial part. It's not made worse by routine activity. Is it annoying? Oh, for sure. But is it going to stop you from getting through your day? Probably not. And that's a huge clue. And then there's the cluster headache. The pain level here is just on another planet. It's often called one of the most severe pains a human can experience. It's always one-sided, usually around the eye, and it comes with other symptoms on that same side, like a red, watery eye or a stuffy nose. But the absolute clinical giveaway, like we saw on the table, is that profound restlessness. The person is agitated and just can't get comfortable. All right, so you've ruled out the scary stuff. You have a good idea of which primary headache it is. But wait, there's one more trap we have to talk about. A real hidden saboteur that can turn any headache into a chronic nightmare. Medication overuse. And you have got to know about this one. Medication overuse headache, or MOH, isn't a whole new type of headache. It's actually the patient's original migraine or tension headache getting way worse. And ironically, it's being caused by the very medications they're taking for relief. It's this crazy vicious cycle where the treatment has become the problem. So how do you catch it? Well, the guidelines make it super clear with these objective numbers. And listen up, because this is important. It's not about how many pills they take on a given day. It's about how many days in a month they're taking any of that medication. For simple painkillers like paracetamol, if they're taking them on 15 or more days a month, you need to be suspicious. For stronger meds like triptans or opioids, that number is even lower, just 10 days a month. You have to ask this question directly. And this quote right here, straight from the guidelines, says it all. There is no magic pill to fix this. The only way to break this cycle is to stop the overused medication, period. It's a tough conversation to have with a patient, for sure, but it is absolutely crucial for them to get better.
Wow. Okay, we've covered a ton, right? From the really scary life-threatening stuff to the nitty-gritty of primary headaches and that sneaky medication overuse trap. So now, let's pull it all together into a super simple, memorable action plan that you can use every single day. And, for your exams.
This is it. This is your game plan. 4 simple steps. First, triage for red flags. Safety first, always. Second, differentiate the primary headaches. Get that history. Third, investigate for medication overuse. Ask the right questions. And finally, fourth, you put it all together and formulate your diagnosis. If you follow these steps in this order, you're ensuring a safe, systematic approach every single time. This is the structure that keeps your patient safe and will absolutely nail those exam questions. All right, that brings us to the end. So I want to leave you with a question to think about. After everything we've talked about, in your next patient with a headache, what's the one question you're going to ask that maybe you wouldn't have before? Maybe it's asking specifically how many minutes it took for the headache to peak, or maybe it's asking for the exact number of days per month they take painkillers. Whatever it is, I promise you, taking this structured approach will make you a better, safer clinician. You'll never look at a headache assessment the same way again. Thanks for joining me.